Good morning, everyone. It's my distinct honor and privilege to talk here in front of you. But before I start my talk, I wanted to mention a few things. First, this is my first time at Cayman Islands. I must say it's a beautiful country. I was at the parliamentary lunch at the Chambers of Commerce. I was struck by the economic growth and prosperity, which really is exhilarating. But most importantly, I really enjoyed my interactions with all the people. They were extremely warm and very hospitable. And obviously, Honorable Catherine Banks-Wells, the health minister, talked about health being a right in part of a developed society. And I could not be more excited with building more bridges between Baptist Health and the people here on the island so that we can work together and serve the community. Because one of the things that I enjoy most being a doctor is, can I take care of people when they are sick? And my journey actually started when my grandmother unfortunately succumbed to cancer, and I was a 12-year-old in India, and I said, I'm going to go to US and I'm going to cure cancer. And now I only get humbled by the journey of my patients, but I get inspired by their resilience to fight. And over the next 45 minutes or so, I'll give you a journey in brain cancer. Brain cancer is one of the most difficult tumors to treat, but I will show you some fascinating results that we've been part of, which has really helped our patients and will provide you more hope for the future, because obviously we are very lucky. We are living in the best era of mankind, where we can translate discoveries from the lab to treatments for our patients. And so as a physician, the best thing is, can you take the latest discoveries and take it to the patients and serve the community? So I'm tasked today to talk about precision medicine in neuro-oncology, shaping the future of brain tumor treatment. And I'll showcase how at Miami Cancer Institute, Baptist Health South Florida, we are partnering with some of the top institutions around the world to make that happen in South Florida, but also around the globe. So I'm going to start off with a topic which I thought would be more relevant, because I didn't want to just talk about primary brain tumors because they are not very common. So I'm going to talk about brain metastases first. And brain metastases basically refers to cancers from the rest of the body, like lung cancer, breast cancer, melanoma, gynecological cancers, that when they go to the brain, it's called brain metastases. And when I started working or got into my training around 2 decades back, sadly, someone who had brain metastases was not a very good diagnosis. These patients, I want you to remember some numbers. There's a lot of information, so I just want you to focus on the patterns and the theme, and don't focus on names of the drugs, okay? My request. But 2 decades back when I started, the outcomes of these patients were pretty grim. They lived 6 to 12 months, and it's a very common disease because 200,000 patients get diagnosed. But you'll see now, I'll present you numbers which are really fascinating. And I'm going to start off with lung cancer, which is because this is the most common cancer that goes to the brain. And previously, when I also started 20 years back, we thought lung cancer was one disease. Now we know that lung cancer is multiple diseases because we are in the era of precision medicine. What that means is we can do genomic profiling of people's cancer. We can look into what is driving someone's cancer. So not only that they have a cancer, what type, what subtype it is, because I will show you how different the outcomes of the patients can be depending on what kind of cancer they have. And just to give you a perspective, 2 decades back, there were a couple of drugs that were approved for lung cancer. Right now, there are 59 drugs that are approved for just lung cancer alone. Okay, so mind-boggling progress. Just to put this in reference, these are some of the curves of patients who got brain metastases from lung cancer, and the most common one is wild type. And here you can see the outcomes are still 12 months. But we see a lot of Hispanic patients, and in Hispanic patients, the most common kind of lung cancer is actually EGFR-driven cancer. This is the one that happens in women commonly who never smoke, and then they get lung cancer, right? Here the outcomes are 2 years. I'll show you some really fascinating data. I just came from Berlin past weekend some really fascinating data where we are doubling survival. But last but not the least is this ALK kind of lung cancer. And I just showed you these patients 2 decades back were living 6 to 12 months. I will show you data now that these patients are not only living 4, 5, they're even living longer. And you'll really be excited to see what I show you. So this is, again, a combination of 2 drugs, a lot of names, so don't pay attention to the drugs. But there's a combination of amivantamab and lazertinib. It's a combination of 2 drugs. And now when you look at the one drug called osimertinib, which is the standard of care for this patient population, you can see now the progression-free survival. What that means is if I put someone on a drug, how long can their cancer be controlled without growing? So this, you can see, we moved the needle from 16 months to 24 months. So remember, these people were living 12 months. Now they are not even progressing for 2 years. And we just had the Mariposa trial results come out. Now these people are living 4 years, which is fascinating, right? Moving from 12 months to 4 years over a period of roughly 2 decades. And when we look at the breakdown, actually most of the benefit is actually being driven by patients who have brain metastases. Because lung cancer patients, when they have lung cancer stage 4, that means the cancer unfortunately has spread out of lung. The most difficult part for them is when they get brain metastases. And if they get brain metastases, which happens around 50% of the time, these drugs now are helping them live longer and are making the overall curve moving to the right. Looking to other drugs, osimertinib, like I told you, was the drug of choice. Now, can we do better by adding it to chemotherapy? And again, very busy curves, but the message is the same. The outcomes are 2 years without progression, and when we look at the survival, 4 years. So the survival improved from 12 months to 2 years to 3 years, and now 4 years in a short period of last 2 decades. So this has been a great journey, and here again, the benefit is being driven by brain metastases. So when patients have complex cancers, that's where they need the best care. And that's what we provide at Miami Cancer Institute, where our neurosurgeons are working closely with radiation oncologists, medical oncologists, neuro-oncologists. But we love to work with the physicians in the community because 80% of the care, even in United States, is actually given in the community. So if we get patients from the island, we like to work very closely with the physicians because they may come to us to get a small portion of their care. Say they have brain metastases, they want the latest technology in radiation. We can deliver it. Usually we give the treatment over a day, and the patient can come back to their family and get treated in the community here. This is a great slide because it shows you the journey of drug development in the last decade. It's amazing how much we've done in the last decade. Again, do not pay attention to the names, but the first drug is crizotinib. It was a first-generation drug against ALK translocation lung cancer. This is a kind of lung cancer that occurs in 5% of the lung cancer patients. And before these drugs came, these are called targeted drugs. What do targeted drugs means? Means we find is the genetics of someone's cancer driving the cancer, the genomics we call it, right? And if it is, can we find what is that pathway that is driving someone's cancer, and we develop a drug just to target that pathway. Before, we used to give people chemotherapy. What was chemotherapy? It was basically toxic agents which would kill any rapidly dividing cells, because that's what cancer is, right? Cancer is a rogue cell or a parasite in your own body which is not following the normal functions of cell-programmed death. What that means is every time someone has a cell in the body that has to do its function, and after some time die. So like the red blood cells that we have, they live for 120 days. But the cancer cell becomes immortal. It doesn't want to die. It wants to grow very, very fast. It wants to suck all the energy from your body. That's why cancer patients are often, they lose weight. They don't have desire to eat because the cancer is really sucking the energy out of them. So now we have these blockbuster drugs. Chemotherapies, when we use them, not only they were toxic, side effects, but the response rates were 5%. So every 20 patients that I gave chemotherapy to, people would have nausea, vomiting, lose their hair. Only 1 out of 20 people would have a response. But now you look at these drugs, and the first generation drugs, you can see 20, 30% response. So rather than working from 1 in 20, it's working 2 out of 20 or 3 out of 20. But look at the last ones, it's 70%. Every 7 out of 10 patients that I'm giving this drug, the cancer is actually shrinking. Not only is it stopping from growing, it's actually shrinking. And I'll show you the best, one of the best drugs now. And so when I ever have residents and fellows who are training with me, I say if the two curves, you can put a finger between the two curves, that's significant. But look at the difference between the curves in the blue. That means the cancer is not progressing at all compared to red. And here you see the response rates are 80% plus. So this was the data which was shown at the recent ASCO. So the red means the patients are not doing well. That's the curve with the first generation. Blue is that means they're doing well. Remember I told you that patients who had brain mets lived 6 months to 12 months? These people, 5 years out, are not even progressing now. Imagine the difference from someone dying in 6 months to going to 5 years, and the cancer is not progressing with these remarkable drugs. So again, can you put a finger through this? Well, you can actually drive a truck through this. This is so much difference. And if you look at the hazard ratio, that's 0.03. What that means is the new drug is 30 times better than the old drug. Okay, that is remarkable progress, because previously when we approved chemotherapies, we said one chemotherapy was better than the other if it increased survival by 3 months. That was the benchmark for the FDA to approve a new drug. And here you are seeing these patients not even progressing 5 years out. So what we think is these people will live 8-10 years out. So they can have a very normal, relatively normal lifespan compared to dying 6 months. So someone who's got a kid who's going through graduation, they can now live to see a grandkid, right? So that's the kind of power we have, what we can serve our patients with. And that is most exhilarating thing for me as a physician scientist, and a doctor taking care of these patients. And this is not relegated to ALK-positive lung cancer. This is a drug called selpercatinib. Again, do not try to remember the names. But this is a kind of lung cancer that's in 2%. But these bars going down means the amount of shrinkage we are causing in the cancer. And the red bar means the cancer is totally disappearing, not only in the body, but also in the brain. So remember I told you, 1 out of 20 times would we shrink the cancer. Here, we are making the cancer disappear. And so these are results which are really making it so exciting. This is again a paper that I and my colleagues from Miami Cancer Institute and Baptist wrote recently. But you can see skyscrapers. We like skyscrapers because that means we are making benefit in the lives of our patients. Moving on to something that we actually led out of Baptist. This was a trial that was done worldwide. There were 4 chairs of the trial that oversaw the study all over the world. And I and my colleague Binesh Mehta were 2 out of those co-chairs, and both of us work in Baptist actually. And the other co-chairs were from Mayo Clinic and Northwestern. And basically, this was a study where we are actually putting these arrays on people's head, which actually gives electric fields that stop the cancer from growing. And this trial was done over a period of 7 years, and basically we looked at the best drugs that we can give to the patient, combined with radiosurgery. And what does radiosurgery mean? It really means it's a very focused beam of radiation. Because one of the things when someone has brain cancer or brain metastases is when you give them radiation is not a good thing, right, guys? Because every time you go and get an X-ray with a family member, what do? They put the patient in the room and tell you to get out, right? Because they don't want you to get the risk of radiation. So when we are giving radiation to treat our patients, we want to precisely target the radiation only to the cancer and not to the area around it. So that's the term we use with radiosurgery. There are terms like gamma knife or LINAC-based accelerators, a lot of medical jargon here, sorry. But the bottom line is what we are trying to do is we are doing the precision of radiation to the tumor to the precision of 1 millimeter. 1 millimeter, okay, and we have some of these latest technologies at Miami Cancer Institute, Baptist. We have the gamma knife, we have the ZAP, we have some of the best tools in the toolbox because that's what you need to take care of your patients. And on this trial that we led out of Miami Cancer Institute with our colleagues, we showed that these arrays, these electric fields were helping people not have the tumor progress longer. Because when people have cancer, the first word they detest most is the cancer growing. So we are preventing the cancer from growing further using these arrays. And these are some of the things that we offer, which is clinical trials. That's the access to drugs and modalities that may not be available outside a clinical trial. And that's why we like to bring the best trials in Miami. Moving on to something which is very fascinating, and this is very fascinating because one of the challenges in brain cancers always has been this issue of blood-brain barrier. What that means is it's the lining around our brain that has been given to us humans as a protection. Because otherwise, every time you would have a blood infection, you could get a brain abscess. You don't want that, right? Brain abscess is not good. So we have this lining around the brain that protects us from infections and bad things to go from the brain. The challenge is when someone has brain cancer, this same lining prevents these drugs from growing in. Okay, and that's why we haven't done as good of a job in brain cancer like other cancers. But now, with this fascinating technology called a blood-brain barrier disruption system, means we can find a way to break that lining using a focused ultrasound. And this particular modality actually happens to be made by a company called Insight Tech, which of all the places in the world happened to be in Miami. And I was working with them even when I was at Cleveland Clinic before I moved to Miami 5 years back. And here, the beauty of this thing is, if you do this focused ultrasound to someone's brain, you can actually disrupt this lining for up to a day. So for a day, the lining gets open, you give the drug penetrates the lining, goes into the cancer, and a day later, the blood-brain barrier reseals. Okay, so hopefully the toxins won't get in. And then you can repeat this procedure every 3 weeks. So we have shown that we can send large molecules. And when I say large molecules, some of these newer drugs, the immunotherapies or the antibody drug conjugates, and I'll explain to you what they are large molecules. They will not cross this blood-brain barrier. But with this ultrasound, we can help it cross. Then we also have shown that when you use it with immunotherapy, if you cause mechanical disruption of this blood-brain barrier, it actually revs up your immune system. So it almost acts like a vaccine on top, okay? So that makes the immunotherapy even better. And so with this, we are leading a trial worldwide, which is being led again out of Miami, partnering with Mayo Clinic. Cleveland Clinic wants to come on board. We are partnering with Johns Hopkins on this and a number of other institutions to see if we can improve the immunotherapy, which is transforming lung cancer outcomes even further using this blood-brain barrier disruption and using the radiosurgery. Next, again, this is a very busy slide, but one of the challenges that we have in cancer has been prediction. And what do I mean by that? When 1,000 patients come and see us, we give them sometimes the same drug. We know it'll work in half. We know that it'll not work in half. But we can't tell which are the half it'll not work in until now. Because now we are in the era of artificial intelligence, right? We are doing very high-level genomic profiling. So at Miami Cancer Institute, we actually do whole exome. So we look at your entire DNA, and then we look at your transcriptome, we look at the RNA. So DNA and RNA changes are driving cancer. And so we have partnered up with Caris Life Sciences, which is a very big platform that does this genomic sequencing. And they looked at 220,000 patients with cancer, and they looked at their whole transcriptome and their genome, and they used machine learning. And with these curves now, we can tell someone who has breast cancer, will they develop brain metastases? Maybe 2 years later, maybe 3 years later. Why is that great? It's because we can follow those patients with MRIs, and we can find the disease early, and we can treat it. So we are living in a very exhilarating era where we can really make differences in the outcomes of our patients. Next, moving on to breast cancer. Breast cancer is the most common cancer, I was told, that you see here on the island. It is also the most common cancer we see in Miami, at the Miami Cancer Institute. And again, here also genomic profiling matters because a lot of women have hormone-positive breast cancer. So we can have drugs which can target that. A lot of women have HER2-positive breast cancer, around 20%. And then there is a term called triple-negative breast cancer. That means none of the hormones are present or the HER2 is present. Unfortunately, these women, and a lot of those women tend to be in their 30s, The cancer is highly aggressive. Oh, sorry. The slides didn't move. I was paying attention on mine, so someone didn't. Okay, well, there's a discrepancy. My apologies. I didn't pay attention to the thing. I was paying attention to my slides. The slides are moving on mine, are not moving on this. Sorry. Thank you for pointing it out. I wish you had done it earlier, but it didn't move. You didn't see the focused ultrasound. Okay, this was the focused ultrasound. Sorry, guys. So this disrupts that blood-brain barrier lining I was talking about. So we put patient in an MR suite. We put them, and I'm sure most people have seen an ultrasound being performed. It is just an ultrasound, but it's to the brain. People get the procedure in the next few hours and get out. And then we can combine this with immunotherapy. This is a trial design where we are working. Okay, this is the genomic assay I was talking to you about. 220,000 people. We looked at all their DNA, we looked at their RNA, and then we did the machine learning. So if you are on the top curve, your outcomes are very different than in the bottom curve. So you want to know that, right? You just don't want to know you have breast cancer. You want to know, are you going to develop brain metastases? Are you going to get liver metastases? People want to know because people want to be treated based on what is likely to happen to them, not what happened to the other 1,000 patients on the trial, which may not reflect them, right? Because we are living in this era of precision oncology. So this is the beauty of this platform, and we are now working with this company to see how can we design new practices. And so this is now finally moving to the breast cancer slide. Okay, so hormone positive is the one which is doing good, and that's the one in the blue. And then there's also hormone positive in the orange. The difference is the one in the blue has both hormone positive and HER2 positive. A lot of information, guys, my apologies. It's just complex. Brain cancer is complex. But the women who have triple negative, these are the women who are in their 30s, okay? They blow through treatment, they break your heart, okay? Those are the ones where they have brain mets. These are the ones in the gray where the outcomes are still 6 to 7 months. Remember that number I told you 2 decades back? This is still a reality for most of these women. So we are working very hard. I was just in Berlin, but there's some fascinating data coming out with the antibody-drug conjugates and immunotherapy together. And I'll show you what antibody-drug conjugate is, and which is really going to transform outcomes for these people. And by transform, I mean we can make them live twice as long. That is really, a lot of progress. And so one of the drugs that did it for HER2 positive, again, this is a subtype of breast cancer, around 20%. And here you can see in the blue curve, the new drugs are so much better than the old drugs, right? I told you before that the drugs would get approved by a 3-month benefit. Here, you can see these curves and the hazard ratio. You see 0.32. What that means is if you're on the new drug, you are doing 60% better, 70% better. So not only just 3 months, you can sometimes double how long these people are living. And so we actually at Miami Cancer Institute are leading this trial nationally. We are combining these drugs, again, with radiosurgery. Remember that very focused form of radiation I told you with the precision to 1 millimeter? Now we are going to combine them to make our patients live even longer. So we actually got a very nice grant, and we have actually established now Miami Cancer Institute as the coordinating center for the International Radiosurgery Research Foundation. That means the Radiosurgery Foundation. This is around 40 cancer centers all over the world, but here you can see there's some very prominent names in the United States where we are partnering, Cleveland Clinic, Mayo Clinic, NYU, Yale, University of Pennsylvania, Emory, amongst others. But we are also partnering with international centers from Canada, Spain, Czech Republic, China, Saudi Arabia, Turkey, Egypt, Dominican Republic. So we are really doing this globally because cancer is a global challenge. It's not only a challenge for us as the United States, it's a challenge for any country in the world. And if you go to most countries, heart disease is still the #1 killer, but over the next 20, 30, 40 years, cancer will really start rivaling that as one of the biggest reasons of people unfortunately dying. So I've mentioned this word before, and this is antibody-drug conjugate. And what does that truly mean? Remember I told you chemotherapies were toxic substances that would go and kill any cell that was actively dividing, okay? It doesn't care, so it's like bomb, okay? It'll go and it'll kill something, but there is always collateral damage, right? That is the challenge with chemotherapy. That's why people lose hair. Their blood counts go down. Why do their blood counts go down? Because, like I told you, the red blood cell in your body changes every 4 months. But if I give it something which is toxic, it'll kill it. That's why people get anemia. They got low white blood count. That's why we have to give them growth boosters. They have to sometimes wear masks to protect themselves from getting infections, particularly true for patients who have leukemia, because we give them a lot of heavy-duty chemotherapy. But what are these antibody-drug conjugates? Antibody-drug conjugates, now you can think of it as a smart bomb. So it's almost this concept of Trojan horse. What we are doing here is, if someone has a protein that is driving their cancer, we are using that protein to get inside the cancer cell, and then we release these payload. And what does the payload mean? It's like that toxic substance inside the cancer cell. Okay, so I'm not just giving it to any cell, it's going inside the cancer cell now. So this is really what we mean by precision oncology. So these are, in a way, a smart bomb. And this is what a complex antibody-drug conjugate looks like. We identify a target, that's this protein. So like I showed you, HER2-positive breast cancer, 20% of women have that. We'll design a drug for it. Then there is something called linker, that is these highly complex chemistries we do in the labs, and then we attach that to a warhead. And what is the warhead? That's the payload that'll go and then kill the cancer cell. And with that now, some of these new drugs are having 70% response rate. Means of 10 patients that I give the drug to, 7 of them will show a shrinkage. You see these bars going down? Bars going down is a good thing. That means their cancer is decreasing, and in some of these cases, even disappearing. And one of the challenges that when you combine this with radiation is that you can have radiation necrosis. That means you've given too much radiation to the brain. And for that, we are again leading a trial throughout Florida. This is being run out of Miami Cancer Institute. We actually got $1 million grant from state of Florida to lead this study. And we are partnering with University of Miami. No, my slides here are gone. So now we're partnering with the University of Miami, Moffitt, Mayo Clinic, some of the leading cancer centers. But we are going to combine radiosurgery and this drug and watch them very closely for radiation necrosis. But that's what we are in now. The cancer treatments are getting highly complex. And that's where when you really need the experts who do these things day in and day out. So like, I'm a medical oncologist, but I only treat patients with brain tumors. I don't treat patients with anything else. So luckily, then I can always concentrate what's going on in the latest and greatest. And that's why you need partnerships. Moving on, next few slides are now looking at new drugs. And now they're drugs which can even protect the brain. Because one of the challenges I told you, when we give radiation to the brain, you have problems in cognitive thinking. Okay, because we are harming the brain with toxic radiation beams. And now we have these drugs which can not only act as a neuroprotectant, but they can also stop cancer from growing. So these are some of the pictures where we have done the first few patients of this drug in the whole world. This trial is actually being done at Miami Cancer Institute. One of my colleagues, Dr. Katocha, is leading it. And here you can see patients who had these brain metastases, which are in the red circles. They are now beginning to disappear when we are using this. And we are designing a number of trials with this compound, not only in brain metastases, but also in glioblastoma. That's the most common primary brain tumor that we see in our clinics. So a lot of excitement going on with this, and this is a new path forward with this. So what are some of the future directions for this part of the talk? We are in, I hope I was able to showcase to you, we are living in a great era where we are now moving outcomes for some of our patients from 6 months to 12 months to 6 years even. Now we haven't done that for everyone. For some it's 4 years, for some it's 6 years. For some of the women with triple-negative breast cancer, it's 6 to 7 months. Hopefully, if I come and give a same kind of talk in a few years, I hope I'll be able to show you the picture that we are doubling or tripling their survival. That's why we get invigorated every morning to get up early so we can go and work for our patients to help them. Then moving on to gliomas. I'm going to talk about 10 minutes or so, or 15 minutes about gliomas. So gliomas now, on the other hand, are primary brain cancer. So this is the cancer that stays in the body, stays in the brain, doesn't go into the body. And Unfortunately, a lot of young people tend to get the low-grade gliomas. These are people in their 20s, 30s. And there's a lot of information here, but there is a particular gene alteration that occurs in these gliomas, and it's called IDH mutant. Again, do not focus on the names, just the themes and the patterns. And when we went to the lab, we found that there was a particular pathway that was driving these genetic changes. So we then went and there was this company called Servier. They designed this drug, and they did a trial throughout United States. And what it is showing is the people who are getting the drug that's in the blue, they are doing much better than people who do not get drug, because a lot of times we'll observe these people because the drugs that we use are chemotherapies, which can be toxic. But here also you can see the benefit is hazard ratio is 0.39. That means 60% benefit of this drug. It's a very well tolerated drug. Patients can get this on for several years. A lot of our patients that we treat in clinic, like I told you, are in their 20s and 30s, and we want to be able to give them meaningful life. Moving on to another kind of a glioma that happens in kids. So this is a midline glioma. It happens in kids, and sadly, until recently, these kids, when they would get this, they would only live around 12 to 15 months. It's really sad, very heartbreaking. Radiation can help them for a small period of time. No drug mattered. But here you'll see this new drug called ONC201. Actually, Miami Cancer Institute and my colleague, Dr. Yazodia, was involved in leading some of these efforts. We worked with some leading cancer centers, and now we actually have a new drug where in these kids, we are almost doubling the benefit that they get when they get this drug, and 20% shrinkage, going from no benefit from a medical therapy to 20% shrinkage. Again, it's building block, right? Life is building block. You don't go from level 1 to level 12 in one go. You go step by step. Next, moving on to meningiomas. Meningiomas are benign tumors of the brain, but they can become a big problem because anything in the brain, it takes a lot of space. It can result in seizures, it can result in stroke, paralysis, and things like that. So we actually found out that this interesting drug that we used to give for thyroid cancer, we gave it to a patient. It's like when you treat people, you learn, right? Every patient, you can learn from every patient. So one of my colleagues, Dr. Katocha, was actually treating this patient, and they had a thyroid cancer. They did also have a meningioma, which was not causing the problem for the patient at that time point. So when they gave this patient this drug called cabozantinib, what they found was, interestingly, not only did it shrink the thyroid cancer, it also shrank their meningioma. So this is a benign tumor in the brain. And on the basis of this, we actually are leading this trial at Miami Cancer Institute, where we have given this drug to patients with meningiomas, and we are seeing very active shrinkages. Again, meningioma is typically a tumor where we have not seen a lot of benefit of medical therapy. They mostly get radiation. So a lot of amazing progress happening when we are learning from our patients. Moving on to something which has been extremely close to my heart for the last 15 years, and that is the development of this vaccine against glioblastoma. So glioblastoma is the most common primary brain tumor. This is the same tumor Senator Kennedy had, Senator John McCain had, son of President Biden, Beau Biden had it. And outcomes of these patients with glioblastoma is not good. Typically, these patients live only around 15 months. And this has been the drug discovery that when I was a fellow training in Roswell Park, Mike Shushilsky and Robert Fenstermakers were the doctors there who developed this vaccine which can target this protein called survivin. And survivin is a protein that is expressed in glioblastoma and not in normal cells. It is actually expressed in other cancers as well. And so what we did was we developed this vaccine which can be given just like your flu shot, okay? Patients come in, they get the vaccine, they go home. They come back in 2 weeks later, we give them another shot. We do that 4 times, and then they need a shot every 3 months. And what we have shown in this trial, the early trial that we did at Cleveland Clinic when I was there, partnering with Dana-Farber in Boston and other Harvard institutions, we showed that the people, instead of living 16 months, were living 26 months. So we have increased the survival by 1 year. In fact, I had a patient I had the privilege of treating, and she came to me, she was just newly married, from Michigan, and her parents were just besides themselves when they found out the diagnosis that her outcome was 16 months. She actually went on to live 6 years without the tumor even progressing. She was on Good Morning America twice. She had 2 kids out of surrogacy by her best friend who was a nurse. It was a fascinating story. Unfortunately, she recently passed away after 8 years. But imagine, to me, that was worth my 15 years of work, helping someone live instead of 15 months to 8 years when she at least had 2 kids who will live in this world beyond her, right? So this is the privilege we have when we are designing these things which can change outcomes from people, not only when we see or worldwide. And the exciting thing is now this trial has been fully enrolled. We partnered with 12 centers all over United States at all these major institutions which are lined here: Roswell Park, Dana-Farber, Cleveland Clinic, UCSF. We had the trial over at Miami Cancer Institute, NYU, and we'll see what the outcomes of this will be. Will it be a new hope for these patients? Moving on, we have another trial that we are leading out of Miami Cancer Institute. We are partnering with NYU, Cleveland Clinic institutions again, because in glioblastoma, I always tell people, go and participate on a clinical trial. Do not get a standard of care, because the standard of care is not good enough. So that's where in the highly complex cancers, we absolutely recommend people getting clinical trials. This is probably my second last slide. Remember that blood-brain barrier disruption system I talked to you about, that focused ultrasound, which breaks the blood-brain barrier lining? Now we are using that for something else. Now in glioblastoma, one of the other challenges we have because of this lining in the brain, a lot of other cancers now we are doing liquid biopsies. And what does liquid biopsy mean? Means we take a tube of blood from you and we go and look, and if someone has cancer, there are cell-free DNA. So there are DNA particles from the cancer that you can actually find in the blood. But in brain cancer, because of the lining, you don't find it. Okay? So if you want to know what's going on in the brain cancer, you have to go and do a brain surgery. That's pretty invasive, guys, right? You don't want your brain cracked open every 2 months to figure out what's going on. So we use this focused ultrasound to disrupt the blood-brain barrier. And what in the previous first trials is shown is it doubles the amount of DNA, the tumor-related DNA we can find in the blood. So this trial is now fully enrolled. Hopefully we might show some improvement, and if that's the case, we will have this as an option. So what are some of the future directions and takeaway points? Now, I hope I showed you that cancer is just not one disease. Based on the genomic profiling of the patients, it is a lot of different diseases with a lot of different outcomes. Drug development has really transformed outcomes in patients in brain metastases and increasingly in brain tumors. Immunotherapy is working really well in brain metastases. Now we are looking at combining it with radiosurgery, these blood-brain barrier systems, to see if we can do further benefits for these patients. We actually surprisingly have had 2 approvals in brain tumors in the last 2 years. The approval before that was almost like 2 decades back. So we are making progress even for these patients. Clinical trials we feel are very important in complex cancers where there are not good outcomes or good treatments. We always recommend people participate on clinical trials. We have that open in Miami Cancer Institute. And the therapy selection is a multidisciplinary approach. What that means is you want a surgeon working closely with a medical oncologist, radiation oncologist, and in cases of brain tumors, even a neuro-oncologist, because you want to have the best doctors putting their best minds to take the best care of the patient. And we always say it takes a village to take care of a cancer patient. So the better people you have on your team, the more likely you are going to have a win. And our patients inspire us every day to do better, to work harder for them. We love collaborating. We not only like to collaborate in Miami, we like to collaborate with people all over the world, because that's how you do. You want to have the best players on the team. That's how you win a championship. And so with that, I would like to thank you for your kind attention, but just offer hope that we are in the best era of mankind. We're going to make transformative changes for our patients and serve our community. Thank you.
We'll start up front and then a question at the back.
Good morning. Thank you. Thank you so much for your presentation, Dr. Ahluwalia. I feel like a brain specialist now. Thank you so much. What does this partnership, collaboration, village that you make mention of look like for cost-effective, accessible, integrative brain, not just brain cancer, but any cancer per se, as it relates to even the demographics of the patients? Because you made mention of one demographic specifically, but I'm just thinking of others. What does that look like for persons accessing all of this, because I'm thinking cost is a factor.
Yeah, that's actually a great question, and I will want to wear now my hat as the chairman of the medical oncology and not a brain cancer doctor to answer that. And the honorable minister had outlined that. One of the key things in cancer care is access. Okay, you may have all these amazing discoveries that I showed you. You're not getting the drug, you're not getting the benefit. So access is extremely important. We are also living in this exciting era, but then there is also a cost to all this, right? In the United States, we spend $4.5 trillion just on healthcare. That's the GDP of Germany or Japan or India, right? These are the number 3, 4, 5 countries in the world. So we have to be very cognizant of the cost of delivery. What I didn't talk about my talk today, and maybe I'll love to come back next year, but I will talk to you about fascinating work that is going on now in cancer screening and using blood-based biomarkers to pick cancers early on. And I think one of the keys is in cancer to actually pick cancer early on, because it's much more cost-effective to treat cancer if you find it in the stage 1 versus stage 4. Because when you find it in stage 4, all we are doing with our best methods, helping people live longer. In stage 1, we can cure them, and they can go back and have a very meaningful life, contribute to the community, stay with their family, and have a fulfilled life. So a lot of part that we are doing lung cancer screenings with low-dose CAT scans. We now have blood tests which look at the fragment of your cancer. And these are really very small fragments of DNA that you can just find with a blood test. We actually ran the study at Miami Cancer Institute, and the test, we are working on making it available in Miami, which can tell people that they can, whether they will have lung cancer. And what we found was we were finding many more people in stage 1, which we wouldn't find. Because the low-dose CAT scans, for example, the requirements are smoking. And what we find out in the United States, that only 5% of patients who should undergo a low-dose CAT scan based on a 20-year pack history of smoking, only 5% people are doing that. If you are in a school, you're going to get a failure, right? You won't get a passing grade. That's what we are doing. So people don't like to go for imaging, but it's easier to go to a blood test where you're going to a primary care, and instead of just imagine a world where instead of getting your blood counts or your body's chemistry, right, your sodium, potassium, you're also getting some of these. The challenges right now is, I think next 5 years are going to be highly exciting, because right now the blood tests which are available for cancer, like the GRAIL test, the sensitivity and specificity is only 20%. What do I mean by that? If I run that blood test on someone, 1 out of 5 times will it pick cancer, and every time it picks cancer or it thinks it's picking cancer, it's only correct 1 out of 5. That's worse than a coin toss. I don't want to undergo that test. But can the holy grail be that we improve that to the sensitivity and specificity of 70, 80%? And some of these newer generation tests will hopefully push us in that direction. There's a blood test called for colon cancer right now, which is helping people. Now, it's not going to replace colonoscopy, so you still have to go and get your colonoscopy, but you can get the blood test at the doctor's office, which is for some patients convenient. So imaging, and I also talked about artificial intelligence. We can pick much better things from the same X-rays that we do. So there's a company called Cure AI, which is even looking at a chest X-ray in less developed countries and trying to pick cancer for that. Because not everyone can have low-dose CAT scans, right? And the uptake rate is 5% in any case, so we're not doing a very good job. So there are amazing, really amazing things coming in terms of imaging, in terms of blood-based biomarkers or these liquid panels, which are really going to help us pick patients early on. And then I talked to you about genomic profiling. We are now getting together to an era where we will figure out, based on your genetic profiling, what are you likely to get? We'll live in an era where at 20, you can tell this person may have risk of Alzheimer's at 70 years of age, right? We are moving towards that world. So it's just a fascinating era. The The question is, can we work together and be fiscally responsible and provide that amazing care to everyone in a cost-effective manner? But that's the question for the Honorable Minister and her leadership.
Okay, we do have time for the other question at the back.
Good morning. I just wanted to say thank you so much for your presentation. My name is Julissa and I'm a student nurse on Island. And my question to you is, have you noticed any neurocognitive side effects in patients who receive repeated blood-brain barrier disruption therapies?
First of all, I must congratulate you. That's an amazing and a very smart question. The good news is no. We have done over 500 of these disruption programs, and we haven't seen any neurocognitive side effects. Now, what I would say is we're still waiting. We don't have a lot of long-term data because this is still a new technology. But think of this, right? Right now, the patients we are treating are living on an average 12 months or 15 months. So the neurocognitive effects that they're having, not that I'm seeing any, is a good challenge to have 5 years down the lane. But that's an excellent question. Not seeing that right now.
Thank you.
Thank you. Let's take this opportunity to say thank you very much to Dr. Ahluwalia of Baptist Health Miami Cancer Institute.